Hi everybody, welcome to the final component of the Pediatric ECGs. This is part 4 and this is where we'll be looking at uncommon Pediatric ECGs, as previously we looked at common issues related to Pediatric ECG interpretation. I'll reiterate this again. This Learnshop, these 4 components are intended for pediatric nurses who monitor cardiac rhythms, and I hope they've provided essentials about pediatric arrhythmias and dysrhythmias. And we have reviewed premature atrial junctional ventricular complexes, and will do so now as well. We looked at tachycardias, supraventricular tachycardias, bradycardia, atrial fibrillation, and these are often conditions associated with congenital heart disease. So what we're going to review now are sinus rhythms, supraventricular rhythms, ventricular rhythms, and life-threatening rhythms, but uncommon, not common. Let's do a knowledge review for the final time. And you should be quite proficient at it if you've attended the previous part 1, 2, and 3. So which of the following is a normal pacemaker of the heart? Sinoatrial node. Which of the following are components of the conduction system of the heart? The answer is D. Which of the following statements represents the P wave? The answer is D, atrial depolarization. Which of the following statements relates to the sympathetic nervous system? They all do. Which of the following statements is correct about the normal heart rate? A, older child 60 to 100. C, younger child infant 35 to 85 beats per minute. B, newborn 50 to 80 beats per minute. The answer is A. The rest are all really too slow. Which of the following relates to the parasympathetic nervous system? A, B, C, or D? The answer is D. Which of the following are standard ECG leads? Lead 1, 2, 3, AVR, AVL, unipolar, bipolar, or all of the above? The answer is all of the above. Which of the following relates to sinus tachycardia? Is it A, B, C, or D? Sorry, none of the above. Which of the following connect to atrial fibrillation? Is it chaotic? Is it rapid and irregular? Doesn't it have any P waves? You're correct. They're all related to atrial fibrillation. Which of the following correlates to a premature ventricular ectopic? Does it come from the ventricle? Is it wide? Does it have an abnormal shaped T wave? Of course it does. All of the above. Now, what's the problem? Premature ventricular complexes that are considered couplet. This is sinus rhythm with couplet PVCs. What's the anomaly? This is supraventricular tachycardia, SVT. What about this rhythm? This is ventricular fibrillation, which is coarse, not fine. What's the following anomaly? Absolutely, you should know this is asystole. What about this anomaly? It's very irregular. This is atrial fibrillation with a controlled ventricular response. Now we're going to review some of the uncommon arrhythmias and dysrhythmias that relate to sinus, atrial, junctional, and ventricular. This is a general term, sinus node dysfunction, which basically means the sinus node isn't working properly. The old term used to be sick sinus syndrome. Another term could be Tachycardia-Bradycardia syndrome. And basically what happens here, the SA node doesn't seem to be working properly. It can be 1 minute very, very slow with periods of sinus pause, It can be very, very, very fast with periods of tachycardia, and it's typically associated with cardiac surgery, medications, which could be toxic, which could be related to digoxin or a beta blocker, or an antiarrhythmic such as amiodarone. But typically the rhythm is something that is fast, slow, no real pattern to it. 1 minute it can be very, very slow, 1 minute very, very, very fast. And with periods of sinus arrest or pause. You've got atrial tachycardia. Atrial tachycardia is a very fast supraventricular rhythm. As we mentioned previously when we looked at the age criteria, in the older child, greater than 160 beats per minute. The infant, greater than 180 beats per minute. In the newborn, greater than 200 beats per minute. And it has abnormal P waves, and it has a narrow complex QRS for the upper limit of their normal age. But it's related to their history and their physical assessment as well, which is very important. You've got something called PAT, Paroxysmal Atrial Tachycardia. Paroxysmal means suddenly. It's initiated by a paroxysm initiation. This is a very fast rhythm, and it's greater than the lower limit for age, more than 300 beats per minute. There's a narrow complex QRS, which is less than the upper limit normal for their age. It's typically associated with congenital heart disease, such as accessory pathways, which could include the Kent bundle, which involves Wolff-Parkinson-White syndrome, James fibers, which involves Langauer-Levine syndrome, Mayhem fibers, which involves AV, atrioventricular, re-entry, nodal tachycardia. All of which we don't discuss here. We will discuss them here in the future in more advanced Learnshops. It can be related to heart disease and digoxin toxicity. Digoxin toxicity can mimic any dysrhythmia, from sinus bradycardia right through to ventricular tachycardia. It can be related to infections or electrolyte imbalances such as magnesium, such as potassium. But the issue is it suddenly starts and it could suddenly stop. Paroxysmal atrial tachycardia. Then you've got atrial fibrillation, which is an uncommon rhythm. However, with congenital heart disease, these infants, children, can be born with congestive heart failure, depending on what their problem is. It can be associated with intra-atrial cardiac surgery, which can be quite invasive and could damage the myocardium. It can be related to Graves' disease or hypothyroidism, and again, digoxin toxicity. Atrial fibrillation is referred to as being very irregular as a rhythm. There are no P waves. Instead, there are what are called fibrillatory waves, wiggly lines, because the atria are actually fibrillating between 300 and 700 fibrillations per minute. And depending on how the ventricle responds to that, it can be fast or slow. So the ventricular rate can be fast or slow. That's what's fast or slow. Atrial fibrillation is always fast. It's fibrillating between 300 and 700 fibrillations per minute. What has to be controlled is the ventricular response. In the first rhythm that you see at the top, this is atrial fibrillation with an uncontrolled ventricular response. It's pretty fast. It's up to 150 to about 200 beats per minute, almost 300 at times. That has to be controlled. The bottom rhythm strip is they're on medication. So it's been controlled because remember, it's the ventricles that pump out the blood. If you now have them beating too quickly, they don't fill adequately and they can't empty properly. So atrial fibrillation, the ventricular response is what has to be controlled. Atrial fibrillation, uncommon. This is atrial flutter, which is another uncommon rhythm, and it's associated with congenital heart disease again, congestive heart failure, surgery, hypothyroidism, and possibly digoxin toxicity. This is a regular, or it could be an irregular rhythm, sometimes referred to as a variable block. As you can see in the bottom rhythm strip here, there's a block of 2 to 1, 3 to 1, 4 to 1, which basically means you've got 2 flutter waves, 3 flutter waves, 4 flutter waves, God willing, not 1 to 1, because that would mean the heart rate would be around about 300 or more fibrillations, or flutters per minute. It's irregular, or it can be regular. There are sawtooth shaped P waves, and as I said, the atrial rate can be very, very fast, from 300 to 150, and it can be controlled. It's the ventricular rate that's variable. The flutter waves are there at being 300. They're all 300. There, you can see them. Then we look at junctional or AV nodal dysrhythmias. And there are 3 common atrial ventricular nodal pacemakers. They can be located above, at the peak of the AV node, in the middle of the AV node, or at the bottom part of the AV node. And if they're located at the superior site above, then you'll see an inverted P wave before a narrow QRS complex. If it's located in the medial site, you won't see a P wave at all. It'll be hidden in the QRS complex because they depolarize at basically the same time. So it's hidden in a narrow QRS complex. Or it can be inferior, an inverted P wave, but this follows a narrow QRS complex. These are the 3 common sites for now nodal dysrhythmias, or junctional rhythms. Have a look at this there. You've got the top one is superior location. Then you've got the middle one, which is medial location. Then you've got the bottom one, which is inferior location. In the superior, you've got a negative P wave in front of the QRS complex. In the medial, you've got no P wave because it's hidden in the QRS complex. In the inferior, it follows the QRS complex. There's no association. So when we look at junctional or nodal dysrhythmias, AV nodal dysrhythmias, the 4 that we're going to focus on are premature junctional complexes, junctional rhythms, accelerated junctional rhythms, and junctional tachycardia. And these can be associated with sympathetic nervous system stimulation, physical activity, excitement, caffeine and cigarette smoking, stimulants, structural heart disease, more problematic things like hypoxia or hypoxemia, electrolyte abnormalities such as hyper or hypokalemia. Then you've got acid-base disturbances, hypothyroidism again, and digoxin toxicity. So a premature junctional complex is very similar to a premature atrial complex. It's regular with occasional irregular rhythm because these premature beats make the rhythm irregular. You can have an inverted P wave before or after the QRS complex, or no P wave because it's hidden in the QRS complex. And the QRS complex is typically a little bit narrower. It may not be for the upper limit of normal age group. Then you've got junctional rhythm. And the junctional rhythm is a slow and very regular rhythm. However, again, it can have no P wave, or the P wave can be inverted before or after the QRS complex. In the rhythm that you're looking at now, it's medial location. It's hidden in the QRS complex. And the heart rates in junctional rhythms are typically, as we stated earlier when we looked at in other workshops, that the rate is typically 40 to 60 beats per minute. That's a junctional rhythm. The SA node has failed for whatever the reason, and the junctional rhythm has come in. Or, here, it can be related to, in most situations, post-cardiac surgery. Atrial septal defect repair, tetralogy of Fallot repair, AV sequential defects, cardiac valve repair, cardiac valve replacement, digoxin toxicity, or antiarrhythmics such as amiodarone. Something has damaged the SA node in the process, and the junctional rhythm is the secondary backup pacemaker that comes in, otherwise your patient will be asystolic. Then you've got what is considered to be an accelerated junctional rhythm, and basically it meets all the same criteria of a junctional rhythm, except for some reason the heart rate is faster, between 60 and 100 beats per minute. It still doesn't have a P wave, or the P wave is inverted before or after the QRS complex. In the rhythm that you're looking at, there's no P wave, so this must be a medial location again. And typically it's related to post-cardiac surgery, it is, or medication toxicity. A junctional tachycardia has got the same criteria, except for some reason the heart rate is greater than 100. Junctional rhythms, we said, typically have heart rates between 40 and 60 beats per minute. If it's accelerated, it's faster. If it's a tachycardia, it's even faster. But again, there's no P wave, or the P wave is located before or after the QRS complex, and it's inverted. And typically it's related to cardiac surgery, because these infants have got congenital heart disease. They require repairs. Now let's look at ventricular dysrhythmias. Dysrhythmia just means different rhythms. Arrhythmias relates to irregular rhythms. We're going to be looking at idioventricular rhythms, accelerated idioventricular rhythms, ventricular tachycardia, torsades de pointe, RLT phenomenon, ventricular fibrillation, and asystole. And these all relate to structural, congenital, ischemic heart disease, or injuries caused as a result of cardiac surgery. It could be related to hypoxemia, acid-base disturbances, or electrolyte anomalies such as hyper or hypokalemia, hypo or hypomagnesemia, or syndromes such as long QT syndrome. Idioventricular rhythm. Idio just means, in Latin, self. So it pertains to the specific ventricular rhythm. It relates to self. And this is a bradycardia. The rate is typically between 20 and 40 beats per minute, which we mentioned earlier. We said if the SA node or the AV node fails, then maybe the third pacemaker may come in, which is related to the Purkinje system. But don't rely on it. It may not. It's very unreliable. It's not really pacemaker tissue. Pacemaker tissue in the heart is only SA node and AV node, not the Purkinje system. Now, the idioventricular rhythm is very slow and regular, and the rate, as I said, is between 20 and 40 beats per minute, and there's no associated P wave. The QRS complex is typically greater than 0.12 seconds. And it's related to all the things I mentioned previously: heart disease, cardiac surgery, and hypoxemia and electrolyte and acid-base anomalies. It's potentially a life-threatening rhythm. Again, it's a bradycardia in all children, so therefore you would be doing CPR in this situation. In an adult or an older child, like an adolescent, maybe not yet, but they would be very unwell. Accelerated idioventricular rhythm just basically means it's faster. It's basically the same. It's faster, regular, rate between 40 and 100 beats per minute. No P wave, QRS is wide. Related to a similar situation: structural heart disease, post-cardiac surgery, severe problems such as hypoxemia, electrolyte anomalies, acid-base derangements. Then you've got ventricular tachycardia, which is uncommon. However, it can occur because they have congenital heart disease, post-cardiac surgery, syndromes such as Wolff-Parkinson-White or Longo-Levine syndrome, long QT syndrome, Kawasaki disease, related to hypoxemia, which can be as a result of birth asphyxia or Brugada syndrome. This is a very fast regular rhythm, and in order to be classified as VT, all you need are 3 PVCs together, and if it's more than 30 seconds, it's sustained. If it's less than 30 seconds, it's non-sustained. Preferably, non-sustained is better, because if it's any more than 30 seconds, they will probably lose consciousness very, 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 very quickly. The rate is typically 100 to 250 beats per minute. The QRS complex is wider than 0.12 seconds, and there's no P wave associated with it. Ventricular tachycardia. What I haven't mentioned, it can be unifocal or it can be monomorphic. Monomorphic means different shapes. Unifocal, one shape, as the one that you're seeing here right now. Then you've got torsades de pointe, and this is just a fancy term which comes from the French. And the French, very dramatic, this is twisting of the points. That's what it means. Torsades, twisting, the, points, points. So it basically means that the complex is negative and positive. And this is a very irregular rhythm. The rate is typically between 300 and 400 beats per minute. There's no visible P wave, and there's no real visible QRS complex. And this is associated with congenital heart disease, ischemic heart disease, possibly post-cardiac surgery, hypoxemia, acid-base disturbances, electrolytes anomalies, and long QT syndrome. And it's got a classic pattern that you see. It starts off big, it gets small, gets smaller, and then it gets big again. Twisting of the points. The R on T phenomenon is exactly that. It's a phenomenon where the R of the wave, which is typically on a PVC, a premature ventricular complex, lands on the T wave, which is considered to be a vulnerable period. It's one of the weakest spots in the ECG complex. And as a consequence of that, if it lands in the wrong place at the right time, the R wave lands on the T wave, this can result in a life-threatening rhythm. And the life-threatening rhythm, as you can see in the rhythm strip below, results in ventricular tachycardia. Or it can result in torsades de pointe. R on T phenomenon. Ventricular fibrillation, a life-threatening rhythm. Not common in pediatrics, but it can be. More common rhythms are related to other things, as mentioned. In ventricular fibrillation, this is an irregular rhythm, and the rate, if you dare to measure it, which nobody really does, can be anything from 300 to 600 fibrillations per minute. There's no visible P wave, no QRS complex. There are fibrillatory waves, and these are coarse, they can be fine, they can be very fine. Sometimes they can be even very coarse. And they're associated with all the things that we mentioned previously: congenital heart disease, ischemic heart disease, post-cardiac surgery, severe hypoxemia, acid-base derangements, electrolyte anomalies, and Kawasaki disease, and many other things. Asystole, well, that's the end. This is typically associated with end-stage cardiac disease, severe hypoxemia. The heart is very dependent on oxygen, as is the brain. There's gross acid and base derangements. There are major electrolyte anomalies, which could include hypomagnesemia, hypo or hyperkalemia, and essentially there is no rhythm. There's no rate, there's no P wave, there's no QRS complex. Sometimes you can get what is called P-wave asystole. I haven't included it here, where there are P-waves but no QRS complex. And as a consequence of that, the P-wave, remember, is atrial depolarization, which is the atria. The important part of the heart is the ventricular contraction, because this provides blood to the systemic circulation. The P-wave just helps fill the ventricles. So in asystole, you've got P-wave asystole, which you can look up if you want to, just Google it. Or you've got here, it's not complete asystole, not correct terminology, it's just asystole. And it's interesting here, when you look at a lot of the Hollywood movies that they make, asystole, often the patient goes into in the emergency department or in the intensive care prior to resuscitation, and they defibrillate it. You never defibrillate asystole, because defibrillation is only for rhythms that can be converted into sinus rhythms, such as ventricular tachycardia, ventricular fibrillation, Torsades to Pont. Asystole, there's no electrical activity, there's nothing to convert. So by shocking the patient's heart, you actually make things worse. Asystole, no rhythm, no rate, no P-wave, no QRS complex, no electrical activity. That's what A means. A means, in Latin, nothing. No systole, which means no cardiac output. So let's revise. Get ready. You've got a 13-year-old child complaining of palpitations, jumping heartbeats. So what's the rhythm? The rhythm that you've got here in front of you is sinus rhythm with what? Couplet PVCs. Then you've got a 10-year-old child asleep in the observation ward. They're asleep. What's the rhythm? The rhythm is just sinus rhythm. Normal. Normal sinus rhythm, I may as well say it here. Normal sinus rhythm basically means that you've got an ECG complex that meets all the criteria. Small P wave, according to the criteria, narrow QRS complex at a rate that is specific. If you, for example, had abnormal sinus rhythm, it may basically mean that the rate is still between 60 and 100, or whatever the age group is for that particular person, but it might be wide complex. You might have a funny shaped P wave. The T wave may be flat or peaked. It's not normal sinus rhythm. Sinus rhythm that's normal meets all the criteria. Then you've got a 2-year-old infant receiving bronchodilator therapy for asthma. What's the rhythm? The rhythm is sinus rhythm for a 2-year-old. Now you've got a 9-year-old child receiving conscious, moderate, procedural sedation in a clinic. What's the rhythm? The rhythm is sinus rhythm with premature ventricular complexes. What about a 4-year-old child asleep in a post-treatment clinic? The rhythm is irregular. Slows down, speeds up, possibly with breathing. This is sinus arrhythmia, which just means the sinus rhythm is irregular. Then you've got a newborn infant with no real problems other than maybe they were sent to the intermediate nursery to be monitored because whatever the reason. This is sinus rhythm for their age group. Now you've got a problem. You've got an 8-year-old child with a history of congestive heart failure. You've got an irregular rhythm. I don't think you can see any P waves. QRS complex is narrow. It doesn't seem to be too quick. This is atrial fibrillation with a controlled ventricular response. So, 8-year-old, he's probably on medication. Maybe he's on digoxin. Digoxin is a very important cardiac medication in children. Not so much in adults, even though it's coming back, but very important for pediatrics. Now you've got a 5-year-old child who's 2 days post-tetralogy of fallow repair. They're probably, and should be, in an intensive care, a cardiovascular intensive care. They're being monitored. What you can see are irregular rhythm, but you've got ventricular, premature ventricular complexes, and these are referred to as bigeminy or bigeminal, which we didn't discuss. Bi just means two, gemini means origin of now here, ventricular from the ventricle, so they're together. Here they're together, they're not couplet, because you've got normal, abnormal. Normal, abnormal, this is ventricular bigeminy. And you can just say bigeminal PVCs. This is a 6-month-old infant with severe malnutrition. When they took the electrolytes, serum electrolytes, they found that the serum potassium was only 2.8, and as you know, normal is 3.5 to about 5 millimoles per litre, milliequivalents per litre, whatever terminology that you choose to use. So this infant is severely hypokalemic. What do you see in the ECG? Well, what you see are couplet PVCs that have evolved R-on-T phenomenon into ventricular tachycardia. Couplet PVCs which have evolved into ventricular tachycardia because of hypokalemia. Then you've got a 6-year-old child with severe hypoxemia and acid-base derangements, which means they're hypoxic, they're probably on oxygen, their pH is very, very abnormal, and this is the rhythm that they're in. I don't think we can see any P waves. And it seems to be slow. This is a profound bradycardia, a junctional rhythm. And this is probably with a medial sighted. So therefore, the P wave is hidden in the QRS complex, but it's a junctional rhythm. The rate's approximately 40 beats per minute in a 6-second rhythm strip. Now you've got a 3-year-old infant with complex cardiac anomalies. And regardless of what you think, this is a bradycardia, and for a 3-year-old infant, you would be doing CPR, I would be thinking. I can't see any P waves. The QRS complex is very, very wide. It's concerning when you look at the 3-year-old infant who's probably pale, unresponsive, and you're going to call a code blue. This is a profound bradycardia with an Idio Ventricular rhythm, which could be a terminal rhythm unless you do something about it. Code blue. Rate approximately 30. Then you've got a 1-year-old infant, post-cardiac surgery. The serum magnesium is 0.45 milliequivalents per litre. Normal is typically above 1. And in cardiac surgical patients here, it should be a little bit higher, maybe 1.5 milliequivalents per litre, because they're very sensitive to now low magnesium. So what are you seeing? What you're seeing is sinus rhythm. It's not normal sinus rhythm because you've got a wide QRS complex, you've got ST depression, but it's sinus rhythm. And you've got R-on-T PVC. There it is there in front of you. The R wave, or you can call it the Q wave in this situation. On the top one, it's Q on T, which we don't call it Q on T, we call it R on T. But you've got R on T in the second rhythm strip, which is just a different lead. There's a sinus rhythm with R on T PVCs. Nothing's happened, but this could go into VT. You've got the same 1-year-old infant post-cardiac surgery, and magnesium is being given, let's say, intravenously. However, you can't give it too quickly. You've got to give it slowly, at least over 30 to 60 minutes. And now they've got this rhythm. And this rhythm basically is ventricular bigeminal PVCs. And they're multifocal. Some are positive and some are negative. Then you've got the same 1-year-old infant not long after. And they've gone into this rhythm here, and you've called code blue. Why did you call code blue? Because this is ventricular fibrillation. This is coarse ventricular fibrillation, a life-threatening rhythm. The same 1-year-old infant was resuscitated for more than an hour, defibrillated, medications, and then they went into this rhythm. And the doctor decided that to end resuscitation after consultation with the parents. And this rhythm is asystole. No electrical activity. Okay, that's the end of Learnshop Part 4, Uncommon Rhythms and Pediatrics. If you enjoyed these sessions, keep your eye out for other YouTube ECG Learnshops, which will include adults in the future and advanced pediatrics and adults. Thanks. See you next time.